Good afternoon, Chair and members of the committee. My name is Erin Catterlin, and I was the lead on this audit. And with me today is my colleague, Jolene Stanislawski. And we're here today to discuss the results of our performance audit, lead testing for children enrolled in Medicaid. But before we get started, I would like to thank both the Department of Health and the Washington Healthcare Authority for their cooperation and their responsiveness throughout the audit. Results from our audit show that the state has not done enough to ensure all children enrolled in Medicaid receive the required blood lead testing at 12 and 24 months of age. And even for the children at the highest risk of lead exposure, the state has not met this requirement. One of the main causes we identified for this was that the state lacks an adequate process to ensure children enrolled in Medicaid receive the required lead testing. And finally, our audit determined that the state could do more to ensure providers have a clear understanding of testing requirements. This audit is important because while people of all ages can be affected by lead, young children are some of the most vulnerable. Children have the most risk factors because they often put hands and other objects into their mouths, and their growing bodies tend to easily absorb what they eat. And exposure to even the smallest amounts of lead can cause serious harm to a child's health, as indicated on the screen. Children may be exposed to lead through multiple different sources, but the primary sources of lead exposure continue to be from contaminants found in and around the home, such as from chipping or peeling paint and contaminated soil or water. Lead can also be brought into the home by an adult from a workplace or by consumer goods. For instance, the FDA has recently recalled several brands of applesauce pouches marketed towards toddlers that were found to be contaminated with lead. And since most children exposed to lead do not look or act sick, a blood test is the only way to confirm if someone has been exposed to lead. There's no safe level of lead in the body, and new sources of lead are being identified all the time. And this is why it is especially important to identify children that have higher levels of lead so that the source of the lead can be identified and removed as soon as possible, and so that the child can get necessary follow-up care that they might need. Medicaid covers the financial costs of blood lead tests for all children that are enrolled and has specific requirements for when children should be tested. All children enrolled in Medicaid are required to receive a blood lead test at both 12 and 24 months of age, or at least once by age 6 if no documentation of a previous test exists. This means that to meet the minimum Medicaid requirement, every child enrolled in Medicaid should at least receive one test by age 6. As of June 2023, there are 240,000 children under the age of 6 that are enrolled in Medicaid in Washington, and therefore are subject to this requirement. 2 state agencies in Washington play key roles in mitigating lead exposure risks in Washington. As the state Medicaid agency, the Healthcare Authority is responsible for ensuring the state meets all federal program requirements, which includes making sure enrollees receive required lead tests, no matter whether they are enrolled through one of the 5 managed care organizations or whether they go through a fee-for-service provider. The Department of Health administers the Childhood Lead Prevention Program with grant funding from the Centers for Disease Control and Prevention, and is responsible for monitoring lead test results in the state. The Department of Health also creates and publishes information about the risks of lead exposure in Washington, and helps promote lead testing statewide through its outreach with providers and families. To ensure the state's efforts, or to evaluate the state's efforts to ensure children enrolled in Medicaid are receiving the required tests, our audit was designed to answer the following questions. To what extent are children enrolled in Medicaid receiving required lead testing? If enrolled children are receiving the required tests, what are the causes for this? And what should the state do to ensure children at the highest risk receive the tests? I will now pass it along to my colleague, Jolene Stanislawski, who will briefly describe the methods that we use to answer these objective questions and provide a summary of our key results.
Thank you, Erin. Good afternoon, everyone. My name is Jolene Stanislawski. To answer these audit questions, we examined two data sets. The first is maintained by HCA and includes eligibility data for children enrolled in Medicaid. The second is maintained by DOH and includes the lead screening results for all children statewide. We compared the two data sets and determined which Medicaid enrolled children were also present on the DOH data set. And to evaluate the performance on the entirety of the federal requirements, we looked at a group of 6-year-olds who were born between 2014 and 2016 with data from 2015 through 2022. Federal requirements state that if there's no documentation a Medicaid enrolled child has been tested at age 1 and at age 2, the child should be tested at least once by age 6. And while 26% of Medicaid children between the ages of 1 and 6 years have had at least one test, which meets the minimum federal requirement, that means 74% of children were untested. And since the data we looked at was for children enrolled in Medicaid during the entire scoping period from ages 1 through 6, we would expect to see that they would have received these tests at ages 1 and 2. And as shown here, 3% of children from the 6-year-old group were tested at the expected developmental stages of ages 1 and 2 years old. And to get more recent results, we also looked at a group of 3-year-olds to see how many had received their tests at ages 1 and 2. This cohort was also useful because it included the time period during the pandemic. We learned that there was actually a slight increase in testing, with 4% of children being tested at the required ages of 1 and 2. And when we compared children 1 through 3 across the two cohorts, the testing results increased even more from 22% to 25%. We will be using the 3-year-olds group results for the rest of this presentation. And because literature, as well as experts, expressed concern that there could be demographic differences for testing rates, we also looked at that. The demographic groups include race, language, and tribal affiliation. Overall, our data didn't show any large differences, except that non-English speakers were tested at a higher rate. And the data does show that children affiliated with a tribe or who identified as American Indian had lower rates. However, labs operate on tribal or federal lands are not required to report their test results to DOH, so they could be testing more often than the data would indicate. But for those results that we did have that indicated a tribal affiliation, there was a higher rate of elevated lead from those results. So we also looked at this geographically. This map, there we go, represents the most recent testing data. And when we looked at testing rates for children tested between ages 1 and 3 in Washington counties, we learned that the testing rate really varied quite a lot. The counties in darker colors had the lowest testing rate, with Ferry County over here getting a low of 2%. And the lighter colors are for higher testing rates, with a high of 55% in Walla Walla. And as you can see over here, King County falls right in the middle. Looking in more detail, those county rates can mask even more variation at the community level. For example, here we have King County. It tests a similar percentage of Medicaid enrolled children compared to the state as a whole at 26%. But testing rates varied across the communities from 0 to 68%. And while we recognize that the requirement is that all children are tested, we also wanted to see whether children living in the highest risk areas were being tested. And we learned that children at the highest risk had not received all the required tests. And to make this determination, we assessed data against the following risk factors, which include the high concentration of elevated blood lead results, homes built before 1960, a percentage of the population living below the federal poverty line, area once used as orchard land, and areas near a former smelter. And we acknowledge that there are additional sources for lead exposure. However, we focused on the ones for which we had available data for mapping. 61% of the children enrolled in Medicaid in our data sets lived in an area with at least one of these risk factors. Specifically, we found children living in riskier areas were tested slightly more than those who lived elsewhere. Please note, though, that this was not true across the board, which is detailed in appendix in our report. We show how some communities have low testing rates with results that show higher lead results. And we learned a little bit more about why we have low rates, and we learned that the state has inadequate processes to ensure children receive the required lead testing. Currently, DOH and HCA work together to identify children on Medicaid who have an elevated result to ensure they receive follow-up care. However, the current methods for data sharing do not allow for determining the number of children who should be getting their required tests in the first place. And nor does it allow for ways to identify which Medicaid providers have billed for a well child visit, but not for a test. These two agencies have been working on a data sharing agreement, and DOH has requested data that should allow them to identify children who lack the required testing and to identify Medicaid providers who have billed for well child visits, but not for the required tests. And then, of course, related to data is how you use that data through things like performance measures. And while HCA does use a federally required performance measure that determines whether children have received at least one test prior to age 2, HCA has not really used the existing performance measure to actively monitor for increasing testing compliance. They do report the results to the managed care organizations, though there's no follow-up beyond that. In fact, HCA's contracts with the MCOs do not clearly state what the expectations are for blood lead testing, as there are no performance standards or thresholds to which HCA would hold the MCOs accountable. Having these in the contract really would strengthen HCA's authority in this area. HCA could improve its performance by developing measures that track full compliance for ages at age 1 and 2, or at least 1 before age 6. And this could really help HCA better monitor all of the requirements. Finally, we also considered those providers who are responsible for ensuring that these tests are actually administered. And we learned providers are not certain about Medicaid lead requirements. Even if providers are aware, they do not typically know if their patients are enrolled in Medicaid. DOH's testing promotion efforts in this area could help improve the awareness, while additional different data analyses would help target those efforts. Along with efforts, HCA could increase awareness around several promising practices we outline in the report. And now I am going to pass this back to Erin to go through our recommendations.
Thank you. Thank you, Jolene. A full list of our recommendations can be found in our report, but in summary, we recommend the Healthcare Authority and the Department of Health coordinate to implement a monitoring process using data the state already has and collects to determine the extent to which children enrolled in Medicaid are receiving the required lead tests and whether children at the highest risk are being tested. Also, that the agencies coordinate to ensure all providers receive clear and consistent guidance from the state about this requirement. And that concludes our presentation, but we would be happy to answer any questions that you might have.
Do any of the members have questions? Representative Pollack.
Thank you for this report. The legislature has addressed some of the concerns in lead, recognizing that even very low elevations in blood lead levels in children can have permanent behavioral and health effects, for a 1 microgram per deciliter increase in blood level, which is very small, the child loses about half an IQ point. So it's really essential we address this. And I was surprised in reading the report that the risk factors described did not include water. And the Department of Health, of course, as in response to legislation, has been screening school water for lead and found hundreds of significantly elevated exposure points. Did DOH identify in your discussions the potential for using school water data as a screening tool? Did they provide the database to you, period? And is there any, and perhaps DOH will also address this if they did not provide that data to you, is there any discussion of screening for early learning and childcare centers as a way of identifying where children need to be screened? Because if they're exposed through a faucet at a childcare center, they're likely to have significant elevations in their blood lead level.
Yeah, thank you for that question. And I'm sure DOH might have some additions to my answer, but we also acknowledge that drinking water is a potential source of lead for children, and we know that new sources of lead are being identified all the time. So what we focused on in our audit was identifying what the state could do to improve its testing rates, because if you test more people and more children, you can begin to identify the sources of those that have elevated blood lead levels. And so we decided to focus on the testing requirement and ways that the state can improve on the testing rates. With that being said, we did look into adding lead in drinking water to our analysis. However, we ultimately found that the data that we needed to be able to do this analysis was not available during the time of our audit, and I'm not sure when the DOH study of the schools was available, if it was available at the time of our field work, but we did not. I don't believe we got that shared with us, but specifically, we did not have any available data to be able to map the potential sources of lead in drinking water at the community level that we would have needed to do the risk analysis that we did in the report.
Representative Paulette to follow up.
You can look at the DOH has a website for hundreds of schools and thousands of faucets tested in schools. Saying room 135 was at 300 parts per billion. Our standard is 5 parts per billion. And that was through 2019, and they have the database for the testing since then under the legislation passed in 2021. I hope DOH will address this, because it's a serious shortcoming, because lead in water is actually in Washington State one of the most likely major sources, unlike nationally where it may be paint in older buildings.
So, Ms. Caroline, go ahead.
Yeah, I just wanted to respond to that. And we did note that, the schools can have lead in their drinking water. However, what we did some research to try to figure out if there was a correlation between a school having a drinking water and there being elevated blood lead levels within the community. And we really did our analysis at the community level, and we did not find any research that suggested any correlation between drinking water having lead in the schools and an elevated blood lead level within the community.
Representative Paulette, did you want to follow up your follow-up?
I'm at a loss to understand this. Correct me if I'm wrong, but you're looking at pediatric exposure and focused on very youth exposure, right? So not community level data. Isn't that right? So if you look and use, I think the policy point here would be we've got a tool in place that could be used to increase the surveillance of youth for their blood lead levels if their school or child care center has elevated water levels of lead, and vice versa. Once a child is found to have elevated blood lead levels, then water should be examined as one of the sources and remediation taken into account. From public health perspective, you've got to do both the surveillance and the response. And the importance, I'd like to ask DOH to address this when you come up.
So, Ms. Stanislawski, if you want to go ahead and respond, and then if we could get Lauren Jenks from Department of Health to respond, please.
Thank you. So, and I think what Aaron was saying, it didn't so much, it wasn't that we couldn't identify it with the community if we had looked at it. It had to do with the data and having the census tract and where children lived. And I'm really glad you brought this up, Representative. As auditors, we were trying to determine, and we did see that on the website, and it really was just a limitation of the method that we used of being able to analyze and map out. And so I'm glad you brought it up, as a parent, that's something that's important. So thank you.
Lauren Jenks, are you available?
Yes, I am. Thank you, Representative Paulette and Chair and Committee. I'm Lauren Jenks, I'm Assistant Secretary for Environmental Public Health at Washington State Department of Health. And as Representative Paulette mentioned, we've worked on lead in drinking water for some time, particularly in schools, and now just recently starting in childcare facilities. And the representative is correct that water is, for Washingtonians, probably our largest exposure source, but it is not the largest cause of elevated blood lead levels. So, and that has to do with a number of things, like we all drink water. So if there is any lead in the water, it becomes an exposure source for a large swath of the population, and therefore is a public health concern. And it's something that as you've pointed out, we are working on, with a particular focus in schools. And when a school water fixture has an exceedance of the lead that it's putting into the water, we work with the school to get that water source replaced so that the kids are no longer exposed. I think part of what we're what the disconnect is here is that the Medicaid rule is for testing of kids at 12 and 24 months, and then at least once by age 6. And that has not a whole lot of overlap with the school age population. There'll be more overlap as we get more and more child cares tested, but right now it's not as useful a measure for the particular question that the auditors were looking at. I hope that's helpful. I'm more than happy to keep talking about that.
Representative Paulette.
The child care, as we expand the child care testing, does DOH anticipate being able to feed that back into the system to identify where children might need to have greater attention to being screened, and vice versa, where children are screened as having elevated blood lead levels, asking to see their school for the 6-year-olds and child care center tested for the younger kiddos?
Yes, absolutely. If we see exceedances, then we do recommend that the parents talk to their healthcare provider about whether their kid needs to be tested for lead. And if we have a child who has an elevated blood lead level, we look at all kinds of potential sources of lead, but that definitely can and does include drinking water.
Thank you.
Thank you. I don't see any other hands online for questions. Do any of the agency personnel want to comment or respond to the report?
I do have some comments prepared. I think HCA does as well, and I'm happy to just kind of go into that if that makes sense.
Please proceed.
All right, thank you. And thank you for everybody, and particularly the State Auditor's Office for their work and recommendations on this topic. We're not surprised by the audit results. A lot of these data are certainly available to us as well. And we know that lead testing rates in Washington are low, and they're not where we want them to be. And we do not believe that enough of the children at risk for lead poisoning are being tested. As we've come out of the pandemic, we've put some effort into building a strong team that's ready to take on this challenge among others. Lead, as you know, lead is still present in the environment, and particularly from paint from homes built before 1978. And we continue to learn about new sources of lead exposure, and we learn about those often because a child has tested positive for lead exposure, and we've determined their source of exposure. There is still much work that we need to do to raise awareness of the ongoing risk of lead among healthcare providers and families. Many of the recommendations that the auditor has provided to DOH are in progress already. For example, we've just now released our lead testing plan, which we'd been working on for some time, but delayed its release to make sure that it was in alignment with the audit report. We've also updated our website and other materials to be clearer about the testing requirements for children enrolled in Medicaid. The Washington Tracking Network lead risk map includes key environmental risk factors, and we continue to update and modify that map as new information becomes available. And we've been working with the HCA for over a year to create a more robust data sharing agreement to allow for matching between the Medicaid enrollment data and the childhood lead test results. And hopefully that will help us to identify mistesting opportunities. And while not mentioned as part of the recommendations from the State Auditor's Office, I do want to acknowledge that this isn't a public health service that Department of Health provides on our own. This is something that we work very closely with our local health jurisdictions on as well. And they've got strong connections to the communities and can help tailor the messaging and outreach in important and effective ways. The findings and recommendations from the State Auditor's Office will allow us to strengthen our efforts to increase lead testing and help us reach our goal of finding all children who are exposed to lead, particularly those who we know are at high risk, and improving their health outcomes. So thank you to all of you, and thank you for allowing me a moment to comment.
Okay, thank you. And with the Healthcare Authority?
Sure. Chair and members of the JLARC committee, thank you for having me here today. My name is Judy Zerzan-Thule. I'm the Chief Medical Officer at the Healthcare Authority. And HCA appreciates this close look at lead testing and the opportunity to improve. We agree with the audit findings and think that much more could and should be done for lead testing in Medicaid children. We realize that further work is necessary, and in fact, we've already begun that work with both DOH and our managed care plans. First, the MCO contract provisions and activities have already been put into place. Prior to January 1st, our managed care contracts only specified that kids with elevated blood levels were eligible for care coordination. As of January 1st, 4 days ago, the contract now requires MCOs to have the following 4 policies and procedures in place to support lead screening. First, facilitating lead level retesting and necessary follow-up referrals for additional care when a screening has been positive. Second, providing provider medical education to encourage lead screenings among patients. 3, developing care gap reports for medical providers. And then 4, ensuring all kids in a home that has a positive indicator of elevated lead levels are additionally tested. And then finally, there's an additional provision to ensure that there's a referral procedure to the DOH Childhood Lead Poisoning Prevention Team or the local health jurisdiction to close that loop between public health and the medical care. With these new provisions, we've increased our expectations that the MCOs will provide provider education, will notify clinicians of care gaps and ongoing services, including that care coordination for kids and families who have elevated lead levels. I also want to point out that 97% of children in Medicaid are on a managed care plan, and so this will really get the bulk of them with that increased education and follow-up. Second, we've ensured our Apple Health policy and guidance that applies to both managed care and our fee-for-service populations aligns with the CDC and best practice guidelines. Here's some language from our EPSDT Well Child Billing Guide that we've updated. Blood screening tests must be done at ages 12 and 24 months. There are two methods for blood screening tests, venous and capillary. Any child between 24 and 72 months with no record of a previous blood screening test must receive one. And a note added, completion of a risk assessment questionnaire does not meet the Medicaid requirement for blood screening tests. I think that this highlighting will help providers understand that it needs to be more than just a risk assessment questionnaire. Third, we've been actively working with our DOH partners on the data sharing and testing rates. We're currently exploring a targeted case management benefit for children on Apple Health with elevated blood levels with our DOH partners, who would be the lead state agency in this work. We'll need to secure CMS approval to implement this and are in the process of understanding the work and anticipated impact of this. Finally, we want to also acknowledge that lead testing does not occur in a vacuum and is one of numerous tests and screens that are critical for children on Apple Health. Beyond the work underway with MCOs and our agency partners, the state will need to continue to prioritize and invest in primary care to ensure that providers are paid adequately and have the time to meaningfully engage with patients, particularly children. We appreciate the work done on this audit. We also acknowledge that we can do better to help individuals most vulnerable to lead exposure be identified, tested, and connected to care and resources to help reduce the long-term impacts. We look forward to continuing to work on this to improve lead testing in our state. Thank you.